Thank you so much, Dr. Degogo Jack, for that insightful presentation. I'm Shayma Kazmi, and I will talk about lung cancer in a different aspect, disparities in access to care. This is the outline of my talk. I will probably go back and forth across multiple topics. We will touch on race, ethnic, gender, socioeconomic, and occupation differences when it comes to lung cancers. The epidemiology, lung cancer screening, treatment of early and late lung cancers, and very importantly, participation in clinical trials for lung cancer. And I will end with a positive note of possible effective interventions to bridge these gaps. So when we talk about lung cancer epidemiology, we appreciate and understand that lung cancer is the most common cancer for the past several decades. The highest incidence of lung cancer is in Central and Eastern Europe and Eastern Asia, and lowest in Central Africa and Western Africa. Some of these differences can be accounted for increased smoking. Geographical variations for incidence and mortality differ in men and women as well, and largely that's attributed to differences in cigarette smoking as well between the two sexes. The SEER data, though, reveals that Blacks have a higher incidence and mortality rate than any other racial or ethnic group. That's 76 per 100,000 person years. Hispanics have the lowest incidence at 37.3 than non-Hispanics, which is 71.9. Regionally, the highest incidence within the United States is in the South, and it is the lowest in the West. It's important to note that Black patients are less likely to receive surgical resection than white patients, which likely contributes to lower survival for early stage non-small cell lung cancers. And we'll talk about that a little bit more later. We also know from SEER data that Black patients were 66% less likely to receive timely and appropriate treatment than white patients. And of the Black patients, Black men were least likely to receive resection, only 22% versus 43.7% in white men. Some of these differences were studied by NCI clinical trial and may be due to the fact that Black men present with typically more comorbidities when compared to the same age white men. And there's also more distrust of the healthcare system in general. Black patients were 51% less likely to receive chemotherapy in timely fashion for stage 4 disease as well than white patients. We know that 90% of lung cancer in the United States is attributed to tobacco smoking, but it's important to note the prevalence of smoking among Blacks is actually lower than whites, American Indians, and multiracial groups. When they studied patients who smoked no more than 30 cigarettes a day, so about a pack and a half, African Americans and Native Hawaiians had significantly greater risk of lung cancer than other groups. So there are other factors at play here besides cigarette smoking. What about lung cancer screening? We know that the National Lung Screening Trial randomized 53,452 former and current smokers, ages 55 to 74 with 30-pack or more smoking history. In these patients, low-dose CT showed a 20% relative reduction in lung cancer mortality at a median follow-up of 6.4 years. What's important to note is 90.8% of participants in the study were white, 4.4% were Black, 1.7% Asian, 2% other, and 1.7% Hispanic. So although demographics associate with improvement in lung cancer survival, such as higher education, former smoking status, fewer comorbidities were less common in Blacks, Blacks had a larger reduction in risk reduction with low-dose CT. Hazard ratio was 0.61 for Blacks versus 0.86 for whites. All-cause mortality, though, was 1.35 times higher in Blacks versus whites. Black race was also predictive of higher likelihood of smoking cessation quit attempt. However, at 6 months, there was less likelihood of continuous abstinence. What about genomics? We know cancer is fundamentally a genomic disorder. However, to date, there's limited research on race, ethnicity, even gender on targeted therapies. We know EGFR mutations in lung cancers have the highest prevalence in Japanese, Korean, and Chinese patients than white patients from US or Europe, and this comes from the IPASS data. But there's conflicting data and frequency of EGFR mutations in Blacks versus white patients. We know that these disparities don't occur with ALK mutations. However, ALK mutations in Asian populations are reported to be 2.3 to 6.7%, versus whites, it's 1.3%, but white patients in Italy and Spain have a 7.5% prevalence. Socioeconomic differences are much harder to tally. However, there have been few meta-analyses. One of them in breast cancer showed a lower breast cancer survival for women with lower socioeconomic status, even after adjustment for tumor characteristics, treatment, comorbidity, and lifestyle factors. Same thing with colon cancer. We know that a systematic review in colon cancer showed lower survival rates in lower socioeconomic groups. We know there's increased risk of lung cancer incidence in lower socioeconomic groups, even when adjusted for smoking status. International meta-analyses have found that individual socioeconomic status and lung cancer survival, there is a weak association with income measures, but no consistent association with education measures or occupation. What about gender differences? So in the US, lung cancer is the leading cancer killer of women. This was surpassed breast cancer in 1987. The lung cancer death rate in women has reached a plateau, though, and now has started to decline by 1% each year. Most of this is attributed to decrease in smoking. Lung cancer mortality has been and continues to be more common in men than women. And when you look at age-adjusted lung cancer incidence, it's higher in men than women, but the magnitude is repeatedly decreased. The incidence of lung cancer in whites aged 30 to 49, though, is higher in women than men, and this is not accounted by smoking differences. And among non-smokers, age-adjusted incidence rate of lung cancer is higher in women than men, and that's 14 to 20 per 100,000 person years versus 5 to 13. And in the US, 19% of lung cancer in women arises in never smokers compared to only 9% in men. So there's definitely gender differences that we need to study more. What could those risks be in women? Evidence suggests that women smokers may have a higher relative risk of developing lung cancer than men. That has a ratio of 1.64 versus 1.43 for men. Air pollution. There has been association with high burden of lung cancer in China, Asia, and Africa in women from burning coal and wood for cooking in unventilated stoves. And this task is usually a burden for women. Endocrine factors, large randomized studies have also suggested that estrogen plus progestin is associated with increased risk of lung cancer. More women are diagnosed with adenocarcinoma and more men are diagnosed with squamous cell carcinoma. So there is differences there as well. And we know that EGFR mutations are more prevalent in women and non-smokers, but there's no such dramatic differences in KRAS, ALK, or other mutations. Prognosis of lung cancer in women is generally better in men, at least in the adenocarcinoma. Occupation. Now, there are very few studies that address lung cancer risk from occupational exposures and the differences with respect to race and gender. There are several epidemiological studies that have reported elevated risks of lung cancer among subjects working in construction and transportation, and these are jobs that traditionally more men will do than women, even after adjusting for smoking. So there is environmental risk. A similar excess of lung cancer is observed for women, but not men in service jobs, such as cleaners, housekeepers, cosmetologists, maintenance workers, and food and beverage servers. And the hypothesis is there's routine exposure to disinfectants, and that could be related. Non-smoking women launderers and dry cleaners are a higher risk for lung cancer. So there's, again, the association with potentially chemicals. Clerical sales jobs are also associated with excess lung cancer risk in women, regardless of smoking status. And the hypothesis there is some of these buildings could have radon exposures, and that could be a potential cause that's understudied. And there's also susceptibility differences between Black and white women. Cancer clinical trials. Cancer research participation varies significantly across racial, ethnic, and age groups. Compared with 1.8% enrollment fraction among whites, yes, it's very, very low all across the board. Hispanics were 1.3% and Blacks were 1.3%. When you look at age variation, ages 30 to 64, the clinical trial enrollment is 3%, so substantially higher, but it declines rapidly in higher age groups. So in ages 65 to 74, it's 1.3%, and 75 and older is only 0.5%, and that is consistent across all ethnicities. Men were more likely than women to enroll in colorectal and lung cancer clinical trials, but enrollment in clinical trials is low for all patient groups. Racial and ethnic minorities, though, women and elderly were generally less likely to enroll in cooperative group cancer trials than were whites, men, and younger patients. So it's really important to appreciate these disparities that we talked about, racial, gender, age, socioeconomic, and ethnic disparities are important to recognize and study. But it's even more important to come up with strategies to eliminate some of the disparities that we see. And this was a multi-pronged approach across 5 NCI cancer centers, and they set out to eliminate racial disparities in early stage lung cancer treatments. And what they created through their electronic medical record system was a real-time warning system tied to electronic health records. And this gave feedback to clinical teams on treatment completion rates for Black and white patients. They had trained nurse navigators that engaged with patients to identify and resolve barriers to care. And at the end of the study, which was published last year, they found a dramatic difference. In the baseline control group, 78% of white patients completed treatment as recommended. Only 69% of Black patients completed treatment. But in the intervention group, 95% of white patients completed treatment and 96.5% of Black patients completed treatment, highlighting the fact that this intervention not only benefited the Black patients dramatically, but also benefited the white patients who had higher engagement, and they really worked on resolving barriers to care and making sure that patients were complying with the recommended and appropriate treatments. So this could potentially be a blueprint for multiple cancer centers, especially since all of them have easy access to electronic health records and nurse navigation is becoming more and more routine in cancer care. So to conclude, we've recognized that there's multiple disparities in lung cancer development, screening, treatment, and prognoses, including but not limited to race, gender, occupation, age, and socioeconomic status. Most of our clinical trial data is skewed towards white men and may need to be interpreted very cautiously in populations that are not adequately represented in these trials. We need to be more culturally aware and train our healthcare providers, physicians, nurses, nurse navigators, and advanced practitioners to be aware of these disparities, and then we can start closing the gaps in these treatment rates that are different among different groups. We need more studies to examine these differences in a prospective setting and to evaluate factors that can be mitigated. Thank you.